And there we've started, ladies and gentlemen. So it's 20:04, 8 Swedish time, and it's the 2nd of May, 2019. And this is a webinar to present the work that I have been doing, Ulf Sandström, from the Peaceful Heart Network, with Gunilla Hamne, my colleague, who wrote the book we were solving yesterday, First Aid for Stress and Trauma with TTT, together with me, and our dear colleague, Stefan Sandström, no relation, who has written this book, which is about addiction, trauma, and comorbidity. Is that correct word, Stefan?
Yeah, comorbidity. Yeah.
Right. And in addition to this, we will say the two more books that we would like you to just be acquainted with is 15 Minutes to Freedom by Harry Pickens, Havening, which is one of the techniques we use in this model for addiction recovery. And the other one is the one just out by Peter Stapleton, The Science of Tapping, with a foreword of Joe Dispenza, Dr. Joe Dispenza, which is about the mountain of meta-analysis of studies that has been done up to date about tapping that figures out why it actually works. So our goal today is to give you an idea about how we have been working with dealing with addiction recovery from a stress and trauma perspective. And we would like to hear your experiences, your thoughts, your reflections on it. We're a lot of people involved in this. Up to date, we have trained, I think, 70 people. Is that correct, Stefan?
Yeah, 70.
Yeah, so 70 people have been trained and they're using this, and they come from all walks of life. They're working addiction recovery homes. They are from social services. They are psychiatrists. They are psychotherapists. And they are people who are not coming from any therapeutical walk of life, but still work with these people. And they need tools to be able to do something, as they say. And it would be great for us just to have a really, really short, like just 30 seconds where you say why you're attending this, so we know, what do you hope to bring away from it? Like if you're working with recovery already, or if you're know somebody who is, or if you've heard about this, or if you're acquainted with tapping or not. So if we could just walk around and you quickly present yourself. And why don't we start with Noreen? Is that okay with you, Noreen?
Yes, that's fine. My name is Noreen, and I am a practitioner EFT, and I've done TTT, and I want to see where this fits in with it and how I can broaden out.
Wonderful.
To help more people.
Yeah. Are you working with addiction recovery today?
No, not at the moment. I know people.
Yeah.
Who are in addiction, but I'm not working with them.
Great. So now you can. That's wonderful. Great. Thank you so much, Noreen. And we'll move over to Dimarp.
Hello.
Yeah. Oh, yeah. My name is Marie, and I'm a social worker in Sweden. And I have, I was in your course, and I try to do tapping and having a lot these days.
Yeah. And are you having any success with it?
Yeah, yes, it's happening. Good
It's
things.
happening. Good things.
Yeah.
Great. Great to hear it. Thank you. Wonderful. Thank you so much. So we'll move on and we'll take John Anderson.
Can you hear me?
We can.
Okay. So my name is John Anderson. I live in Hamne, Sweden, and I work as an addiction therapist in Falkenbergs kommun in a 12-step program. And I'm very interested in this model. That's when I'm attending this video seminar.
Yeah. So have you used tapping or havening before?
No, I worked with Gestalt therapy.
Okay.
But not with tapping or havening.
Yeah. So both tapping and havening actually have a version where you do Gestalt or role havening, it's called. So where you integrate them. So that's cool. We'll get back to that. Wonderful. Thank you. How about Bettina?
Hi.
Hi.
I do reflexology and mindful tapping, and I've taken a course quite a few years ago for Gunilla and Ulf. And I have worked with girls with self-destructive behavior and addictions before, and so I have a special interest in that area. So when I saw that this was coming up, then I thought, oh, I want to find out more about this. And being that I meet people with all sorts of different problems that come for reflexology or tapping, then I thought that this would be good to know.
That's
And
a
I
good
live
thing.
in Mora in Sweden.
Yeah, wonderful. Okay, great. Thank you. That's cool. And we'll go over to my colleague and Gunilla's colleague, Fredrik Presto, hypnotist and NLP practitioner, master, and tapper.
Yeah, hi everybody. I'm a hypnotist, NLP trainer, mental trainer, and I use tapping a lot and also a lot of havening. Ulf and I have a lot of cooperation. We have a daily pod together, and we do a lot of stuff. We're writing books, and I'm also, yeah, as you said, Ulf, a friend of Gunilla's as well.
Cool. Wonderful. And thank you, Fredrik. That's great. So I'll mute you and we'll go over to Noelia. Should we try you again? Give it a second try?
Hello?
Yes.
Do you hear me? Yes.
We do.
Yes, hello. I'm a school counselor in a small city outside Gothenburg. And before I was working with a woman that was violent in home. And so I understand that trauma was very important to talk about. And then I understand that children with sexual abuse also is suffering from trauma. And then I have family with addiction, so I connected everything.
Everything. Yes. Christmas.
Yes.
Yes.
Like that.
Yes,
Yeah.
I understand. Thank you. You're so welcome. So, you know, and also for all of you, just so you understand, this is for all of you to share. We have materials for you that we can send to you afterwards. The book that Gunilla and I wrote, Resolving Yesterday, you get it for free. It's a PDF and other stuff. So keep in the loop. The trainings we do in Stockholm. This is to find out, you know, how interested you are, if this is useful. Do you find it something you'd like to put into the work you're doing? And we will probably be doing some kind of online training in this as well in the future, but that's still to be resolved. So thank you so much, Noelia, and thanks for being straightforward with everything. And we go over to Astrid. You're online, Astrid. Oops, you muted yourself. I was too fast.
Okay. Hi everybody. I'm so sorry. I'm late. I just arrived a few seconds ago. So
beautiful. If you just say 30 seconds, you know, who you are and what you hope to gain from participating here. What made you curious?
Okay, thank you. I'm German. I live in Munich. I'm a learning coach. So I work with students who have, for example, just one example, what made me curious to join this webinar. I work with students who have fear to make their tests. And so they cannot live their full potential. They have fear. They have blackouts. They are shocked, and I help them. I'm a hypnotherapist, and I work with them quite successfully. But I think the tapping method is faster and easier, and it's self-help for them.
Yeah. That's true. Peter Stapleton, who wrote this book that I told them about, The Science of Tapping, she's been conducting studies that are published with anxiety for school exams with tapping in Australia. Tapping in the Schools is the name of her program. And also, you know, a lot of people, 7 out of 10 have fear from school of public speaking, and a lot of people with severe traumas actually go into self-medication, which is why addiction recovery with this also is very useful.
Yeah.
So that's great. Thank you so much. Have you ever been to Heidelberg to the Reden Reichnitz conference?
Yes, of course. Last time, yes.
Yeah, and I'll be there this year as well. So I'll be talking about havening there.
Great.
If
So
you're coming, I'll see you.
yes, in Heidelberg. Yeah.
Right. Beautiful.
Yeah, great. Thank you.
Thank you so much. So we're not going to be able to go through everybody because it'll be long, but we'd like to get just a very quick idea because we can't see you. So we don't know if Maria or Malin or Ulf or HP250, if you're there. So unmute yourself and just give us a short intro in whatever order you want.
Okay, can you hear me?
Yes, we can.
I'm Ulf. I can hear you. And,
so am I.
Yes, I know that. I've been working with drug addicts for 30 years in a treatment center in Sweden, and now I'm working as a psychotherapist in Barcelona and in Sweden with the drug addicts. And I'm acquainted with transactional analysis. I know Stefan a bit, and also with Gestalt therapy.
Cool.
And I haven't used tapping or havening, so I'm just curious about this technique.
Well, you should be. We're happy you are.
Yeah. Thank you.
Wonderful. Thank you. What about Maria?
Hi, Maria Forsberg. I live just outside of Stockholm. I'm an ICC coach, using tapping on my clients and just starting with the havening process. I'm looking forward to be able to help my clients using these different kinds of treatment methods. So I'm really looking forward to what you guys have to say tonight.
Beautiful. Thanks a lot for that. Malin Mulder? Malin? Nope. How about HP250? Do we have you there? Not either. Okay, so that's all good. When you wake up or you hear this or something isn't working, once it does, we'll be fine. So in short, just to give a very short summary before we put Stefan on the mic, I work with Gunilla. We've been working with tapping in a very special modality for over 10 years now. It started out when she wanted to find a way to help refugees. She was a journalist working with the World Children's Prize. She's on a ferry right now in Greece. She's been in Lesbos working with refugees in Moria refugee camp with 4,000 people right now and pretty harsh conditions. We're working there together with Katrinos Healthcare, which is a team of doctors working there with the health for these people. And we're doing a study there as well with blood pressure and tapping. So she was working as a journalist, and she found that she needed a way to help people without having to disclose their issues, without having to talk about their trauma, because talking about it can actually be re-traumatizing. So she invited Dr. Carl Johnson from the US, who had been working in Kosovo with war survivors, and he did a very special TFT algorithm, thought field therapy, which is a tapping modality that was the first one developed by Roger Callahan. And it builds on muscle testing and things, and it's very precise, and it tries to locate where in the body there's a certain blockage, and then you help that by tapping on certain points. Now, after thought field therapy, something came called EFT, Emotional Freedom Techniques, by Gary Craig, which basically was saying, instead of muscle testing, which takes a lot of time to learn, why not tap all the main points? So there are 13 points that you could tap. So Gunilla did kind of a combo of these. EFT has affirmations and talking. That does not work in a cross-cultural context where there's a lot of rape and a lot of crime and a lot of violence, because talking about things is not something you want to do in a group setting. It actually is re-traumatizing. The concept of the EFT affirmations of saying that you love yourself despite this and that doesn't really translate. So she was doing TFT with the algorithm of Carl Johnson, which is a very simplified tapping procedure. And the whole gamut point and eye movement was replaced by alpha theta breathing, which means breathing where you actually slow the brain waves down. So when I joined her, it was a year or two later, we started to make sure that this technique called trauma tapping technique really worked well as a peer-to-peer technique. So the whole idea is that it's taught for people to learn and to do themselves on themselves and their community. So the only way we could spread it is as peer-to-peer spreading by laymen. It also works wonderfully as a main therapeutical method. So you could see it as a emotional first aid in one setting, and you could see it as a therapeutic complete method in another way. From there, we moved on and we met through friends, Dr. Ronald Rudin, who had been studying tapping for 16 years at that time, 20 or 30 years now. And he was trying to find out what is it that actually is the science that makes this work, because the whole idea of tapping comes from stimulating points that are acupressure points in the body. So you're basically stimulating the same points you would stimulate in acupuncture. And the idea of acupuncture comes from traditional Chinese medicine, which means it talks about energy meridians, which in a scientific community doesn't always make people open-minded, because there are second opinions about what energy meridians are and how they work. So he looked at this from a strict scientific perspective, going, what is actually happening in the body, in the brain? How is trauma encoded? How is it decoded? How is stress coded? How is it decoded? And he found that not denying or neglecting the energy meridian model, but there's just another model which looks at how touching parts of the body in a certain way will lower heartbeat, lower cortisol. It will calm down the nervous system. It will downregulate the sympathetic. It will upregulate the parasympathetic. It will enhance one of the brain waves, which is normally associated with, wrongly, deep sleep, because we have it also in our waking state, which is the delta wave. And the delta wave actually releases certain enzymes in the body that can help the amygdala, which has encoded a certain stimuli in a traumatic memory to trigger a certain reaction, and this can be depotentiated. So that's the whole idea of havening and the science of tapping, which, so in one book you can read about the science of tapping, and in When the Past is Always Present by Dr. Rudin, you can read about his model, but it's the same science at the bottom of this. And basically, when we heard about him, we sent him a mail saying, we love your book about the science. What is this havening stuff? And he said, oh, you haven't seen it? Welcome to London. Be my guests. I'll give it to you and just spread it, because that's what he wants. So he wants people to be well-trained and know the science. And I am a havening trainer, so I teach it and I do courses, but we also include self-havening in all the work we do in up to 30 countries by now, where we work with helping people resolve trauma. So it's really efficient. It's two different methods. They work on the same mechanisms. And from here, we go to a conference about trauma in Sweden. And as I'm sitting on this conference, listening to different people, it was like maybe 30 different keynote speakers. I go into this conference where this person called Stefan Sandström is supposed, I said, that's a cool name. And that's him waving. And I go, he's going to be talking about addiction and recovery. And I go in and I listen 5 minutes, and he has me completely, my full attention, because he's talking about trauma, about addiction recovery from a completely different perspective than the traditional one. He's looking at how stress and trauma is involved, and also how different types of addiction actually appeal to certain needs in people. And I wrote that down. I said, Stefan, here's our book. We had just come out, we were solving yesterday. Let's talk. And then many years later, Stefan has learned havening from Dr. Rudin, and he knows I do it in Sweden. So he contacted me and Gunilla and said, I work with recovery from addiction. I've been doing this for 30, 40 years. I've written books about it. I know how well havening works and tapping. Why don't we do something together where we put together the practical experience that we have from working with and teaching trauma tapping and havening with his 30, 40-year experience of addiction recovery. And I'll give the mic to you, Stefan, and you can explain the rest of your perspective of this, and then I'll take over again after that. And we'll have an open Q&A session on this. But basically, through Stefan, I understood more of transaction analysis, which is fascinating and very useful and extremely efficient, just like these methods. But that's not all you've put into this, Stefan. You put in other stuff and your stuff, which is very unique. So please, the mic is yours, and you will have full screen, and there you go.
Okay, here I am. Yes. Yes. So I'm a licensed psychologist in my own practice. And I have been working with drug addicts for more than 35 years, just like you said, Ulf. And after 35 years, I sat myself down and I thought, so what have I learned from this? And I found three things that I learned. And I will show them to you, I hope. I'm not very good at this. Let's see, how about that? You should see a PowerPoint right now. Do you see that?
Yep, it looks good.
Okay, that's very good. The first conclusion I came to was that people abuse drugs because they have intolerable feelings. Because I haven't met one drug abuser yet who was feeling good. And so this was kind of the perspective of self-medication. You medicate yourself because your feelings are intolerable. It has a similarity to how psychiatry uses drugs. But if you go to a psychiatrist and to get drugs to tolerate your feelings, you just get enough drugs so that it's not any fun. But if you medicate yourself, you can have a party plus. So that is the main reason that I see. The second conclusion I came to was that these feelings result from traumas to a great extent. And I based that on meeting up with traumas in almost every client I worked with during this time. I mean, it's like maybe a couple of thousands of hours of psychotherapy or so. And the third conclusion is that acting out, which is a great problem in treatment because very often this is what terminates treatment. You know, you're breaking the rules and you get thrown out of rehab. And my conclusion is that acting out, when it's dramatic, is more a result of flashbacks rather than a lack of social boundaries. In Sweden, we tend to think that it's due to a lack of social boundaries. And so we want to do bordering interventions. We want to teach these people borders and to abide by rules. And this is not feasible when you have a flashback, because the flashback doesn't pass through any kind of reflecting portion of the brain.
Gunilla, I have a reflection about that in Sweden. When addicts are acting out at rehabs, professionals often claim that the person is not motivated and they never talk about trauma. That's completely true. And that is an enormous problem because they call it acting out, while in reality it is a traumatic flashback. And to shame somebody who's having a traumatic flashback is basically like telling somebody with a broken leg that they should shape up, which doesn't really work that way. So yeah, that is one of the issues why we think people should be trauma-informed. Stefan, are you with us?
Yeah, I'm with you. These were my three conclusions, that people abuse substances because they have intolerable feelings, that these feelings result from traumas to a great extent, and thirdly, that acting out when it's dramatic is a result of flashbacks rather than a lack of social boundaries.
Yeah.
Yes. So the third point is really important because this is where a lot of treatments terminate because of acting out, because of hitting somebody, because of running away, because of taking drugs, and this kind of dramatic acting out behaviors. And this is understandable as long as you consider them to be a lack of social boundaries and you try to reestablish these boundaries by a set of rules. But since in a trauma situation, the impulse doesn't, in the flashback situation, the impulse doesn't pass through any reflecting part of the brain, it is impossible. You cannot stop this acting out. It is something that stems from the original trauma. If you want to stop it, you have to stop the trauma. Okay, so next picture. Then I started to write my book, and I found out that international scientific community had done a lot of research on this, and that there is a great comorbidity between PTSD and substance abuse. So, for example, there is this study, the first study that I cite here, means that there is between 36 and 50% of those who seek help for substance abuse in the United States suffer from lifelong PTSD, which is not really, normal PTSD, but it's a qualified form of PTSD where you have reason to believe that you will not be able to cure it. And there are 6 other studies that confirm that the percentage in these cases are between 30 and 60%. So that is a lot, of course, in itself. Now, the fact is that PTSD is not the only type of trauma. If we look at the diagnostic criterions for PTSD, it's said to occur when you are subject to or have witnessed death threats, serious injury, or sexual violence. So basically, if you have other traumatic experience, they do not count as PTSD. But you can see here on the picture, I've listed some very traumatic situations, like school bullying, which is a traumatic situation that will follow many people through their whole life. And family members who are imprisoned, psychic abuse, family members that have mental disorders, psychosis, severe depression or whatever, parents that are abusing drugs, experiencing severe shame, physical or psychological neglect, or involuntary imprisonment. So these are all situations which do not meet the criterion for PTSD, but they are all bad enough to drive you to suicide 30 years later. So they are really severe traumatic situations. Okay.
Mm-hmm.
So next picture. So basically, if trauma is not treated, then the main reason for substance abuse in many people is not being addressed at all. There is a severe risk for relapse because the trauma will be present for probably many years, or maybe for the whole lifetime. Life quality is also substantially diminished for the client. So if you do not treat the trauma, your possibility of successful treatment goes down considerably. The most important trauma to treat really is the early abandonment trauma, which you will find underlying attachment difficulties in personality disorders and psychosis. So that is really something which maybe 80–90% of the clients with severe drug addiction will have, and which is really very important to cure. And for that, you will usually use attachment work. Attachment work is also extremely important in order to resolve drug abuse and drug addiction, because most people who have severe drug addiction have no one that they can trust in their social networks at all. And this means that they have no ability to form functioning relationships. Now, there are some people with drug problems that can form functioning relationships, but I would say that the majority can't. And functioning relationships are necessary for being able to function in work life, relating to colleagues, relating to bosses, for residence relating to your neighbors, for family life relating to your partner and bringing up children. Social rehabilitation generally refers to relationships. The word social without relationship is a paradox, because then it would not be social. So basically, I came to this second conclusion, that you do have to treat both traumas and attachment problems. That these are the main points. Without them, you cannot really succeed. If you let out people who can't form functioning relationships, it's not going to amount to much. If you let out people with who are severely traumatized, it usually will not relate to much. And generally, they will try to deal with the pain by taking drugs. So that's kind of the conclusion I came to, and I said to myself that I will my last years in this profession, I will use them to try to bring trauma into the mainstream abuse treatment in Sweden. And so I put up a Facebook page about this, and I had coursework in this. I had lots of courses all over Sweden. And after a while, I realized that even though people totally agreed with me in my conclusions, they didn't begin to treat trauma because they didn't know how. And that's when I came to think about Ulf and our very nice meeting at that conference that you mentioned before. And the fact that we better get out there and teach people to treat trauma. And that is what we are doing now. We're teaching people to deal with this and to treat trauma at the same time. Okay, so that was that.
Yeah, that was that. Thank you. Let's see if I can get this to stop sharing. Let's see, stop share. And we're back now to the speaker view, right? So thank you, Stefan. So yeah, basically the whole idea of this is not only to know that stress and trauma are causes. I mean, because basically you could say that the three parts of a therapeutic intervention, number one is create a safe space for something to happen. So as a therapist or a therapist, you need to create a safe space where people have confidence in you enough to try to do something about their situation. Step number two is correct any imbalance, and stress and trauma are imbalances. If you don't correct the imbalance of stress, then you're not likely to be able to get rid of the self-medication. And in the same way, if you don't correct the imbalance that trauma creates, it's going to be really tricky to install the third step, which is install the skills that are missing that got you into this situation in the first place. And one of those, like Stefan says, is that of attachment. If you don't have the skill or the strategy of how to attach to other people, even if you do temporarily get off an addiction, once you are back out and you still can't attach to any relationship or work or relations or any flock of some kind, then basically you'll bounce back into self-medication. So this is the gist of it. There are more parts to it, and parts of what that is that, Stefan, if you could just touch really lightly, I know you didn't intend to do this, but I think you do it so well, on what is called in Swedish livspositioner. What is that called in English in transaction analysis?
Basically positions, sometimes life positions, and occasionally existential positions.
Yeah.
That is what it's called in transactional analysis. And the roots of this goes back to the English object relation theory, with the positions of that were thought out by Melanie Klein and by Fairbairn. This is quite a very complex subject to explain in a short time.
Yeah, it is in one way. And in one way, I think it's a wonderful subject because it really sums up. I mean, we do this course, this training that we do is 2 days plus 2 days. So the first day of the 2-day training is theory with Stefan, basically a longer elaboration of what he told you now, going into details, going into specific cases, giving examples, explaining the concepts. And on the second day of the first 2-day training, me and Gunilla teach how to use specifically tapping and havening in the context of the stress related to substance abuse. Now, when it comes to substance abuse, the difference is being an addict actually is traumatic in itself. So while trauma can cause self-medication, addiction causes trauma. So it becomes a self-perpetuating loop. There's shame involved in having an addiction. Having an addiction, you are often forced to lie. You are often forced to break the law to maintain your addiction. So there are so many layers of complexity that make this a self-perpetuating loop. And to break the loop, you need to break the circle of shame, the circle of trauma. So we teach trauma tapping in the context of working with a client, basically very simply, not having to retell their whole story, but having just simply relating to all the issues involved in this. And then tapping is done on the person. I know if you're in the States, depending on where you are and depending on your profession, you are or you aren't allowed to touch your client. In Sweden, we always do the tapping for the client because we find it more powerful. But it can also be done as self-tapping, as a follow John. Same thing goes for havening. But that's one aspect, the stress and the trauma of coming from this. The other thing is that what actually triggers or seems to trigger most often for people a relapse into addiction is when they are stressed. It's a response to stress. So when life becomes stressful, the one pal they have that has helped them out before to calm them down is the self-medication. Now, if you do tapping or havening, which is a very simple procedure like this, if you do that, when the craving arises, you basically, in 12 to 20 minutes, the craving actually goes away and stays away for a while. It can pop back, but you can actually tap and haven on the actual craving. So it's not only about resolving life stress and trauma that led to self-medication, but also trauma caused by and stress caused by self-medication, and then the actual craving. So those are the first 2 days. On the second 2 days, Stefan teaches a full day again, which is about, like he said, life perspectives. And he has a take on it. Let's see. He has a take on it, which I like a lot because it looks at these life positions and life perspectives and connects them to other things. So yeah, you're back online, dude. That's wonderful.
Yeah.
See what happens. So
out here in the bush.
Yeah, that's what happens. So I was just saying, on the second day, you teach more of that, more of attachment theory, and also, again, more specific cases. We talk a little bit also about self-harm. When you self-inflicted harm, it comes in different categories.
Cut yourself.
Yeah. So could you talk about that for 2 secs? I mean, we're not going to be deep into things, but we want to give a general idea.
Sure. Well, basically, when you're teaching self-harm, at least here in Sweden, I don't know how it is in other countries, we teach it like there is one type of self-harm, there is one type of cause behind this, and there is one way of treating it. And this, of course, is nonsense, because basically what we teach here is that there are 3 ways of harming yourself. There are 3 reasons for harming yourself, and there are 3 separate treatments that you need to apply. each for every one cause. So firstly, you have the people who are depressed, and they harm themselves out of self-hate. And some of these people, they are consciously hating themselves, so they like to harm themselves because they hate themselves and they feel that's good. Then you have the ones who are not conscious of hating themselves. They hate themselves, but it's unconscious. And they will mostly feel that when they cut themselves, they have a release of anxiety. The anxiety level drops. So that's pleasant. Basically, when you have these two types of self-harming, it doesn't matter if you give them attention or not. It's maybe better to give some attention to them as people. Then we have people with personality disturbances, and particularly with borderline personality disorders. And they do self-mutilation, self-harm in order to get attention. That is a main goal of these people. They need to get attention. Basically, everybody needs to get attention. We do have a biological need of attention from other people because we are a herd animal. We don't live separately out in the fields. We live together. We go together in communities, villages, towns, and cities. And it has been proven over and over again that we can't live without attention. For example, we have the old study of Dr. René Spitz that you might have heard of, who proved they were having a problem in the United States with in the homes where they were keeping children who were little babies who were up for adoption. And there was an enormous amount of children that died without no visible cause. I mean, they got food, they got diapers, they got drink, and everything that they needed physiologically, and still they died. And René Spitz, he was no idiot, so he began to see why are they dying. The first thing he did was to study where in these big halls were the children who died the most. And of course, they were the furthest away from the entrance. So these were the little children who got basically the food and drink they needed, but they didn't get the love. They were too far away. So they died from a lack of love. Also, my old anthropology teacher who was working with the Amazonas Indians, he told me about how these tribes would not have a death penalty, but they had a penalty for severe crimes to treat people as if they were dead, which is not to notice them, not to talk with them, not to give them any attention. And he said after 6 to 8 weeks, they actually died.
Yeah.
We don't see much of that because we live together with other people, and it's very easy to get some kind of attention. All you need to do to get attention is go out in the street and kick somebody, and you'll get lots of attention. It's going to keep you alive, for sure. But so generally, most people, we can hold attention. When we have been together with other people, we can hold attention. We have had enough attention, and maybe we want to be by ourselves for a while, and that can feel even pleasant. The problem for borderline personality disorder people is they cannot hold attention. They need to have constant attention. Have you noticed that? They always need to have attention, and they often revert to very dramatic behaviors in order to get this attention. So, and cutting yourself and hurting yourself. One woman, she would eat light bulbs, actually, in order to get attention. Another woman, she would eat dinnerware, knives and forks and spoons and all that. And this is in order to just to get attention. So their attention is a difficult subject. many people who work with borderline say, don't give them attention because it never stops. And I think that's a bit like if you're walking in the Sahara Desert and you see someone who is coming crawling from, you know, from the south, totally black in the face from dehydration, and your body tells you, yes, don't give him anything to drink because he will never stop. You see? So my take on treating people with borderline personality disorder is more like, you know, stay very tight to them, totally tight, and don't abandon them. When you finish for the day, when you finish for the weekend, be very specific, tell them exactly when you're coming back, exactly what you're going to do, be totally clear with that.
And didn't you also say that that's something to think about, because when people, once they do get a little bit attached to you and they do get a trust in you, then maybe you're not going to be coming back to work for 2 days because you need to do something else or you're sick or something, and they can have a complete reaction to that, which is extremely negative, even suicidal.
Well, you know, exactly the abandonment, abandoning these people triggers this early abandonment trauma. Yeah. And that is the worst that a person can experience, more or less. It's totally terrible. So anytime that you begin to abandon them, they will begin to act out. And all their primitive defenses are going into action.
Yep. And that's what
happens.
And we have another question online here. It's for the FAQs, but we'll do it now.
I have one more time.
Oh, beautiful.
And these are people with psychosis, like schizophrenia, very often. They get into something, they get into this feeling that they begin to think about, you know, themselves, and they construct a very mental model. And many of them come to the point where they begin to wonder, do I really exist? Which is, we call annihilation anxiety. And that's probably the worst kind of anxiety that you can have. So it's really, really terrible. And in order to manage this anxiety, these people, they will particularly burn themselves and sometimes cut themselves in order to feel pain, because the pain proves their existence. So you see, these are 3 types of self-harming situations, and I have not heard anybody say, well, one type exists but not the other 2. You know, it's totally clear that all 3 types exist, and it's totally clear that they are based on various different diagnoses and that you have to treat them differently. One thing to confuse all this a bit more is to say that sometimes you have both the borderline version and the depressed version, and you can alternate between them. And then it's pretty difficult. You must know which one you're dealing with. So yeah. That was that.
That's beautiful. Thank you. And there was another question, and I'm not sure if we can answer it now and today. We can just touch upon it. For the FAQ, Maria says, how to address or treat attachment issues?
Well, you have to form relationships, basically. And when you get the client, it's much better to start immediately. Often, if you are running some kind of unit, you want people to come in and to settle down and to begin to find themselves at home before you start. But it's much better if you start immediately to take contact, to show that you're open to contact, not to force yourself on anybody. Then it is very much a question of interaction and of understanding the problems of the client. In order to understand the problems of the client, you have to listen a lot. Many people, they talk a lot. But what is more important is really to listen a lot and then to understand. we want to tune into the clients so that they feel that they are being seen. This is a very important experience when you're doing work. Of course, we can't go through the whole attachment work here, but I can tell you one thing. My wife, she works a lot with attachment with her clients who are adult drug abusers. And when we have been discussing our experiences of this, we have come to the conclusion that the decisive moment in many treatments is when you do something that you do not have to do for a client. You know?
An act of kindness.
Yes. When you do what you have to do, everyone understands, well, it's work and they have to do that, otherwise they don't get paid, etc., etc. Even, you know, like doing psychotherapy and so on. But there is a great sensitivity for many of these clients to when you're doing what you didn't have to do. So, for example, one time my wife, she was with this male client, and he was very worried because he didn't have a toothbrush. And he felt he was smelling badly from the mouth, and he was worried about tooth decay and so on. And immediately, without thinking of it, Kerstin, my wife, she took up a toothbrush from her bag and gave it to him, saying, "Here, you can have this." And this was not a big thing. It was not at all a big thing, but she didn't have to do it. She didn't earn anything. She didn't get a higher pay for doing this. She didn't get a better standing and so on. And it just was an incredible experience from him. And he was extremely glad and happy. And now, a couple of months later, he is cured and he's living a drug-free life. And he is even got a job, you know. Yesterday, she did another of those things. There was this girl who had her birthday, and she bought her a little basket of strawberries. You know, not a lot of money, but the response is the same. You wouldn't have had to do that for me. If you do for to do, then it is a personal act of kindness, and somehow you must like me.
And which also means somehow I must be likable.
Yeah.
So Noelia has another question to that. She said she worked like this because it came very natural, but it started to create opinions about colleagues, thinking that they thought you were getting along too well with the clients, and it was turning into private. Because I mean, the danger is that you form some kind of new symbiotic dependency there.
Yes. You have to learn to distinguish between unhealthy symbiosis and healthy attachment. You know, and to realize that in attachment work there is dependency. Necessarily there is dependency, but it has to be a healthy dependency. Yeah. And you can see that I have a great symbiosis model, but you can see that if the client begins to exclude parts of himself or herself, if the therapist starts to exclude parts of herself or himself, then the risk is that you may have a symbiosis. But otherwise, you know, healthy attachment work, it includes dependency as well. The client is supposed to become dependent on the therapist.
Yep. Yeah, and I could see that earlier. I mean, that is a question that pops up usually, and it's, like Stefan says, if you have a very clear idea about where the border goes between healthy and unhealthy, and can prove it, because it's very easy, like you explained before, Stefan, it's very easy for some of these clients to take advantage of friendship and create what is the symbiotic unhealthy relationship, and that's when you suddenly find yourself doing things that you shouldn't be doing, which go beyond friendship. So Ulf is saying he has to leave because he has to eat something. Still interested? I want to have the PDF we talked about. Thank you very much.
Food dependency, huh?
Yeah. We tried to stop eating. I mean, because
yes, absolutely. Thank you very much.
Did you enjoy it?
Yes, very much.
Wonderful.
So we keep in contact, and as I said, I'm still interested and really want a PDF. And I mailed with Stefan before that I'm really interested in the course too. So
yep.
Yes, great. I hope I will be able to come someday.
Okay, we got something going on in Malmö and Stockholm this autumn.
Yeah. Yes.
It will be good. We'll send you stuff and you stay in touch.
Yeah, absolutely. Thank you very much.
Wonderful.
Okay, bye.
So beautiful. So, okay, so we're 2112, and I think we've covered most of the general outline and some specific cases. I want to share one more thing before we go into Q&A. So basically, there are different ways of looking at what people say they want and what they actually need. And just to show you how closely trauma can be linked and how uncomplex it can be, Frederick, I don't know if he's still here, but he had a client just a couple of weeks ago that we were discussing that came to him and said, I would like, you know, I have a cocaine addiction and I feel very bad about it. It's putting my job and life at risk. It's illegal. I want to stop. So he asked the client basically, when do you use cocaine and why? And the client says, I only do it in one case. What case is that? It's when I've been drinking abnormally, and so I can stay awake and drink more. Okay, so why do you need to drink more and so much that you need to stay awake using cocaine? And the client says, I drink that much when I have anxiety. So, okay, so Frederick just took a chance and said, do you have access to that anxiety right now? And the client says, yes, I do. I can sense the anxiety. So it was exposed. It was there. It was open. So he applied tapping in this case on the actual anxiety. And after that session, one session, which isn't always the case, but surprisingly often 1 to 3 sessions is enough, the anxiety was dissolved, and he was in touch with the client a month or 2 later, and the need for drinking and the need for cocaine was gone. So basically, I mean, that is, in that case, it isn't really an addiction. It's a self-medication. And the client wasn't really addicted to cocaine. The client was addicted to using alcohol to resolve anxiety. So that's an example of how treating the trauma can actually sometimes dissolve the need for substance. Okay, so we'd like to see if you have any questions for the Q&A now, because we have like 10, 14 minutes left. You can ask them in the chat, or you can unmute yourself and ask them. That's fine. We'd be very curious to hear how this fits with your view of the world and your experiences. And if you'd be interested, if we're contemplating if we should do this as an online training, in addition to the live trainings we're doing. It would be different because you don't really sit a full day in front of a computer, but it would be possible. So please, share your thoughts. Astrid? No thoughts?
No thoughts, no questions. Many answers. I got many answers. So
okay.
We're being clear. We are being too clear. We should confuse things a bit.
Yeah, more smoke and mirrors. That's what I believe in.
I just ordered the book you showed us before.
Yeah. Oh, wonderful. Great. Well, good. Well, stay in touch. You know, we will be announcing more stuff to those of you who have been here, and we'll also send this recording out. What about you, Noelia? You have any more questions or? No, you're good.
I think I have been waiting for these 2 years now that someone will bring this up the combination with the traumas and addiction and so on. So I'm very happy.
Yeah, that's wonderful.
Generally, our idea is a bit that there are very many ways, very many methods. You know, there are 12-step, there are Gestalt, there is transactional analysis, psychoanalysis, and this and that. And that basically people should continue treating with the methods that they are treating, but they should add trauma work and they should add attachment work. And then we think that they would be much better off.
I agree.
Yeah.
I read your book, Stefan. I bought it and read it in 3 days.
Okay, thank you. Thank you for getting it.
Yes.
Yeah. So yeah, and we do believe in passing this knowledge on to as many as possible, because like Stefan says, anybody involved with people who have an addiction or those behaviors even that could lead to an addiction, when there is stress, when there is a stress and trauma informed caregiver, they will do it differently. A lot of people that have been coming to these trainings, they say they do the 12-step recovery program. They're sitting in a group, they're sharing information. For some people, sharing it feels great because they're finally seen and heard and received in a safe space. And for some of them, it kind of unwinds a lot of traumatic emotions. And when they leave the meeting, they're actually not in a better place than they were when they came. And it's not always easy to see who those people are. You might not see it on the outside. So what we propose is, and what people have been trying, is that you incorporate this into the 12-step program. After a sharing in a group, you do a mutual session where you actually do the self-havening or the tapping. And in that way, you take care of it without actually singling people out, saying you need help and you don't. That make sense?
Yes. Can I ask, do you think it's work at children, this method?
Absolutely. Absolutely. Yes.
Yes.
I can say for sure. We've been doing it with school children and liberated child soldiers in Congo, kids orphans from the genocide in Rwanda. Peter Stapleton has been doing it, who wrote the book Science and Tapping, in Australia with school kids.
Yes.
The National Foster Healthcare System in Costa Rica, there's a medical doctor, Christine Holthaus. She has incorporated trauma tapping in the National Foster Care System.
Wow.
So it is part of that.
Yeah, that's good, because I meet a lot of children from Syria now that is acting out at schools, and the teacher is like, they are so aggressive, and it's so long queue to the BUP, and so we think in our school that we must do something because there are so many and they feel very bad.
You know, actually, at this, have you heard of Tydelsdagarna in Halmstad?
Yes, I read about it at internet. So
yes, so we were going to have one course. I mean, we have had full courses since last autumn. We have had 4 full courses in Stockholm, and we have had one course in Gothenburg here in Sweden. And now we try to have one, you know, and these have all been for drug abuse. Now we try to have one in this great conference for people who were working with these refugee children, but we didn't get enough people to hold it.
Oi.
Yeah.
Crazy. Isn't that crazy?
Yes, that is very crazy. Because
crazy. They need it the most, you know?
Yes. That is so crazy, because we, in that small community that I work, we are like 5 schools, and we are struggling with the same problems with these children. They are very aggressive, they are angry, they don't trust us, they're working at schools. And I think near Gothenburg it must be even more from where I work. So
yes, so this you would need a trauma-informed, you know, professional method. You would need to be trauma informed about what trauma means and what it does to children, and also to get good methods for your counselors and psychologists and nurses and other people who would be able to treat this immediately on site.
Yes, but I think the problem is because from what my principal said, that we school counselor can't give treatment in school because we are not psychologists.
Well, this isn't treatment, so never mind.
Okay, very good. So,
this is one good thing about tapping and havening. There is no negative side effects. This is why it was so ideal to choose this. Sweden doesn't work well with traumas because we haven't had any wars.
No.
The United States work well with traumas, and the UK works well with traumas, and Finland work well with traumas because they have had wars all the time. We have had peace, so we don't work well with traumas.
No.
And we have nothing to offer.
No.
So what we want to do now is that we want to build a legion of good trauma treatment personnel in Sweden.
That sounds perfect.
And in any other country that might be interested in it.
Yes, I will share one funny story or very sad story. I have a family member and that has borderline. He was abandoned when he was little and sex abused and so on, and a lot of drugs. And we went to the social services, and I said that he need therapy for his trauma. And the social services said no, but he can do just aggressive replacement training and he will fix this. And I was like shocked that they don't understand the complexity of this.
That is not a problem. The problem is that they think that they understand the complexity.
Yes.
That is the problem.
That is the problem. Yes, I agree.
Yeah, you see, and also with the treatment that we have and that we offer in institutions in Sweden is usually exposure treatment, where you expose to your own traumatic situation and you have to get into them. And as Ulf pointed out earlier, more often, every now and then, you get too overexposed and you get a new trauma from that. So there are lots of people who have lots of bad experience from that. And this makes people very nervous with, easy treatments like we are doing.
Yes.
They're too easy to do, so you don't trust them. But the thing is, they are more effective. I have been treating trauma for 35 years, and more than that. And I have been using the old methods. I never go back to that now.
No.
Never. I haven't done it once.
Yeah. So you will have this course in Malmö this autumn?
Yeah,
yes,
in Malmö and in Stockholm.
But also saying that if you have 5 schools that would not like this, if you talk to them, you could arrange so we could come down. We could do a training for those 5 schools. Don't worry about it. So talk to them. It's not very expensive. It's extremely useful. It helps everybody, and everybody can learn from this. It's about your safety as well, because if you try to correct a person who's in a flashback as if they're acting out, that can be actually very dangerous.
Yes.
So knowing this and understanding this and how to communicate with low affection, it can actually be a safety issue more than anything else.
Yes.
We're going up to Borlänge to work with to educate the work group there in just a few weeks.
Oh, yes, it's quite far away from me.
Yeah. I'm just saying they can do it. They got one from their work group.
Yes. Yeah. I can talk to my schools where I work, and I hope they will be interested.
Wonderful. We have a free app also with tapping that is for kids. So it's called Self-Help for Trauma. It's in 27 languages, including Arabic and most of the refugee languages spoken in Sweden. So you can just download it for free on Android and Google.
This.
Yeah,
Self-Help
it's over
for
there. Yeah.
Trauma. Yes. Okay.
So we're going to wrap this out now because we're getting close to that time. Thank you so much for all of your interaction. We hope you enjoyed this. Bettina and Noreen, do you have anything to add to us?
I was just going to question about havening.
Yes.
I don't know a lot about it, and I'm interested in how you integrate the tapping and the havening together.
I'm so sorry. I should have thought about that. Yeah, my fault. Okay, so we teach self-havening. Havening is a technique developed by Dr. Ronald Rudin and Steve Rudin. They're twins. It's about, instead of tapping on the body, you use the bilateral stimulation. So if you want to do this now, this is self-havening. You put your hands on your shoulders and you pull down, right, like this. Fairly fast. And you're stroking, and it's not supposed to be, you know, you're not cuddling yourself. It's a treatment. And you do this, and as you do this, basically you're enhancing your delta wave, and you are lowering cortisol and heartbeat. You're doing bilateral, bihemispherical stimulation,
right,
which leads to depotentiation. So this is the absolutely simplest one. You can also do it on your face. It's like washing your face like this.
Yes.
And you can also, and like this with your hands. There is more to actual havening treatment, because actual havening treatment, you learn how to differentiate between different kinds of issues, difference between a phobia and an anxiety and chronic pain that comes from PTS. But if you just want to have, if you have somebody on the phone, I do a lot of phone and Skype sessions, and sometimes on the phone you can't see people. So you tell them, put your hands together and make small circles, and you should feel the palms of your hands tingling, like tickling.
Yeah, yeah.
And then you say, do this and put your phone on speaker and let's continue talking. So if they are in an anxiety attack or they're very sad or depressed or angry and they do this as you talk, basically as they're talking, they're keeping themselves exposed, and this is actually helping it dissolve. So after 5 minutes of this, you know, people usually calm down.
Right, so you just use this, just use these simple, 3 simple techniques mainly.
Yeah, plus the complete trauma tapping. You know, the complete trauma tapping technique is you start here, right, and then you go on your forehead.
Yes, I've done the trauma tapping.
Yeah, so for the rest, so it's here. These are the points under the arm.
Yeah,
and then it's the fingers, and then it's the 2 breaths. You breathe in through your nose.
Yeah, yeah.
Breathe out and sigh, and then you repeat the procedure.
Yeah.
So
and where do you fit the havening in?
Well, you don't fit it in. You either or you combine them. So, for example, if you have a person who's highly sensitive, who has a migraine, or who is in a flashback of acting out and really hypervigilant, tapping can be quite provoking for the nervous system.
Yes. Yeah.
And havening is a lot calmer.
Right. I understand.
And also for a person who, for a child, it's a lot easier to apply this immediately, you know that?
Yes, yes.
And the other way around, there are situations where people have had extreme traumatic experiences and they want to do something about it, and this just doesn't reach through in the same way, then tapping feels more like a method, like a treatment to them.
Yes.
So basically it's like, you know, do I want to use a hammer or a drill? Well, it kind of depends. Sometimes you need both, and sometimes, you know, one or the other.
And you don't need to have been trained in havening to be able to use it.
No, because this is a simple self-regulation. I mean, it's called self-havening, right?
Yeah.
So you're not using it, in this case, the tapping, you can use therapeutic if you want, but the self-havening, you're just teaching self-regulation.
Yeah.
Right? Now, the rules for havening techniques are quite clear. It is not okay to say that you are a havening practitioner unless you are, which you aren't unless you've done the training and the 30 cases and the science assessment and all that.
Yes.
But it's fine to use to teach self-havening to people. And I'll send you a link after this to Pastor John Obanyo in the refugee camp in Bidibidi in Uganda. They were taught self-havening, and he created a song with this that they're singing with some community leaders, which is just completely fabulous.
Okay.
And because we usually do that, we teach the techniques in music because it's easier to remember.
Yes, I've seen them and they're brilliant. Is there anything that can be applied more into the English community? I mean, I love the African ways.
Well, we do have the song in English. I'll send you a link.
Yes, I've seen it, but do you understand what I mean? To have anything that English can watch in English with English people.
Yeah.
Material?
You have
English material on your website, yes.
Yeah, there's plenty of material on the website.
All right.
Loads and loads. And also, their website is peacefulheart.se.
Yes, yeah.
And it says learning materials and videos, and it's on the front page. You can just go straight to the videos. And also the app that I told you, it's completely language free. So instructions are in English, but you don't need to understand English to watch it.
Okay, thank you.
I think it's worth to say that we teach a little more than this when we teach it. No.
Yes, yes. I understand,
this is just as much as we can communicate very, very quickly.
Yes.
And another aspect of using havening is that I teach my clients is if they're in a situation where they can't use tapping because it might seem very odd or strange to others, they can always use the havening technique, saying, "Oh, I'm a bit cold," and rubbing their upper arms. Or,
yes, of course.
When rubbing the palms of their hands, saying, "Oh, I think it's a bit chilly inside," or anything like that, and it makes it a more natural way. And people
thank you.
as much as if you're using the tapping technique.
And I'd like to add to that. I think that's very, very good. Thank you. So who was that talking?
Maria.
Oh, sorry. Yeah, because I couldn't see who was talking. So yes, and I would add to that if you come to a scene where an accident has happened, for some reason people are sitting around and you would like people to just calm down fast, you can, in 10 seconds, you can say, "Can you do this?" And they go, "Yeah, they can do that." "Okay, do this until I come back."
Right.
So it's an instruction of 3 seconds to have people starting to self-regulate.
Yeah.
And that's kind of tricky to do with tapping.
Yes, it is. Yes. Right.
Okay.
Thank you very much. Thank you.
So yes, who had a question?
For the course, do people have to have any experience in tapping or havening before?
We teach you everything from scratch.
Okay.
So
and more information on the course, where is it also on the website?
Yep. And I'll send, well, you will get an email probably tomorrow morning with information about this. That's the website. I put it in the chat. It's in Swedish. We will have English information as well, but you'll get a short summary in English.
Okay.
Okay.
Right.
Thank you very much.
Thank you, everybody. So thank you, everybody.
Thank you.
It's been wonderful. Thank you.
Thank you.
Thank you.
Take care.
Much.
Namaste.
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 Okay. Bye-bye.
Bye.